Motorized spiral enteroscopy, results of an international multicenter prospective observational clinical study in patients with normal and altered gastrointestinal anatomy. Introduction. Device-assisted enteroscopy allows for direct endoscopic access to the small bowel with the option for tissue acquisition and therapeutic procedures. However, deep enteroscopy is a challenging and time-consuming procedure and, in particular, visualization of the entire small intestine is usually only achieved by experts in enteroscopy using device-assisted enteroscopy techniques. Motorized spiral enteroscopy, using a novel enteroscope, was recently introduced into clinical practice and represents a new technology, namely self-propelling enteroscopy, that is a technical refinement of the principle of spiral enteroscopy. An integrated electric motor is used to rotate a short spiral overtube at the distal part of the insertion section of the enteroscope. Motorized spiral enteroscopy was recently shown to be effective and safe for antegrade deep enteroscopy in terms of diagnostic success rates, procedural duration, and depth of maximum insertion in an initial prospective pilot study. In an additional prospective study involving the same 2 European centers, the novel technique achieved total enteroscopy using an antegrade or combined antegrade and retrograde approach in 70% of the cases. However, these results were achieved at 2 tertiary referral centers that already had vast experience in motorized spiral enteroscopy after an initial learning period. Furthermore, patients who had undergone major abdominal surgery and with surgically altered anatomy were not included in these trials. These patients may be at higher risk of procedure-related adverse events. For these reasons, the current large, multicenter study was designed with the primary objective of assessing the safety of the technique in a real-life setting, including appraisal of learning curve aspects and with investigations performed in patients after previous abdominal surgery, including with altered gastrointestinal anatomy. Methods. Patients with indications for deep enteroscopy were enrolled in a prospective observational multicenter study. The primary objective was the serious adverse event rate. Secondary objectives were the diagnostic and therapeutic yield, procedural success, time, and insertion depth. Data analysis was subdivided into training and core post-training study phases at centers with different levels of motorized spiral enteroscopy experience. Results. 298 patients, of which 120 were women, and with an age range of 19 to 92 years were enrolled. In the post-training phase, 21.5% had previous abdominal surgery and 10.0% had surgically altered anatomy. Overall, serious adverse events occurred in 2.3%. The serious adverse event rate was 2.0% in the core group and 4.3% in the training group, and was not increased after abdominal surgery. Total enteroscopy was achieved in half of the patients undergoing planned total enteroscopy. In 87.5% of procedures, the anatomical region of interest could be reached. Conclusion. This prospective multicenter study showed that motorized spiral enteroscopy was feasible and safe in a large cohort of patients in a real-life setting after a short learning curve. Motorized spiral enteroscopy was shown to be feasible in post-surgical patients, including those with altered anatomy, without an increase in the serious adverse event rate.